Hola, thank you for joining our team from the University of Arizona and the Colegio de Sonora as we share our project on Metasalud Diabetes. Mexico, as many of our countries, faces major problems with high rates of diabetes and obesity, and we have limited resources. To address this problem, we designed Metasalud Diabetes, specifically for self-help groups already existing in the Mexican health system. Metasalud Diabetes provides a 13-session curriculum for secondary prevention of diabetes complications by promoting salutogenic and healthy lifestyle changes through participatory methods. This program includes a handbook for facilitators and a workbook for participants and is free to download. Our first aim was to determine the effectiveness of Metasalud Diabetes for secondary prevention of CVD risk by conducting a cluster randomized trial in 12 intervention groups and 10 control groups in centers run by the Health Ministry. We measured behavioral and biomedical indicators at baseline, 3 months, and 12 months. Our second aim was to assess the feasibility of Metasalud Diabetes implementation and scale-up. We collected information through detailed observation of all 13 sessions with feedback meetings with facilitators, fidelity scoring, contact logs, and stakeholder meetings. Normalization process theory, cornerstone of implementation studies, some would say, was used to analyze this information and answer the questions regarding how pertinent social actors act and react in relation to this intervention and make it work. Now, let's take a look at our results.
Some demographic information to start. We worked in 22 community health centers and recruited 518 patients with diabetes. 85% were women and their average age was 60 years old. We used the Framingham risk score to measure cardiovascular risk, and we found a significant reduction of CVD risk in the intervention groups, which was maintained at 12 months, that is, 9 months after the intervention was over. Another important finding was a significant decrease in perceived stress among intervention groups, which we measured using the problem areas in diabetes scale. Emotional well-being is an important component of the program, so we expected to see changes at 3 months, but we were pleased to find that the changes were maintained at 12 months. We also saw a decrease in the consumption of sugary drinks and an increase in the consumption of vegetables, which are two of the goals that participants work on throughout the program. However, vegetable consumption was still nowhere near the 5-serving minimum recommended for cardiovascular risk reduction. We did not find any significant changes in cholesterol, blood pressure, fasting glucose, or hemoglobin A1C, and levels for both groups were above those recommended for diabetes control, possibly due to issues with the availability of medication within the health system. We also saw very low levels of physical activity in both intervention and control groups, with no significant change after the intervention, possibly due to physical challenges reported by some participants and a lack of urban infrastructure. And now some key findings from AIM-2, the qualitative implementation study. We used normalization process theory to systematically identify challenges to program maintenance and scale-up. We observed that, although facilitators found the program useful and congruent with their perceived role as health educators, it was not maintained after research activities were over because of their heavy workload and competing health center demands. They were able to implement the program as designed, but did not recognize that it could help them meet federal accreditation requirements for diabetes self-help groups, which focus on biomedical indicators. So program maintenance and scale-up will require changes in institutional support, supervision, and training, which we are currently working on in collaboration with state and federal authorities. As we continue to analyze AIM-2 data, we are engaging with multiple stakeholders to modify the accreditation standards for diabetes self-help groups, enhance the role of the health center staff who facilitate them, and provide them with more resources so they can implement and maintain effective, highly participative programs like Metasalud Diabetes. In particular, and because of COVID-19, we're currently generating online resources to provide continuous training. So far, we've published 7 academic articles in peer-reviewed journals, and 6 are currently under review. We've put all intervention materials online, we've generated policy briefs, and have produced a series of infographics intended to make our research results accessible to the patients who participated in the project and to the general public, which we're disseminating across a variety of media platforms.
Mixed methods research is increasingly recognized as being highly valuable because it can capitalize on the respective strengths of qualitative and quantitative approaches. Pairing qualitative and quantitative components in a study can achieve various aims, including corroborating findings, generating more complete data, and using results from one method to enhance insights attained from the complementary method. Metasalud Diabetes was very successful in this regard, with a robust quantitative component involving a cluster randomized controlled trial to assess clinical and behavioral outcomes, and a diverse qualitative component involving focus groups, interviews with key informants, stakeholders, and federal and state government officials in different settings from a large geographic area.
We'd also like to talk a little bit about the contributions of the study to the field of implementation science. As a team, we realized pretty early on that Metasalud could be a vehicle to elevate health promotion within clinical settings that were primarily focused on curative care. But we realized in doing so that we really had to identify benefits and incentives for health promotion, not only for those delivering the intervention, but also for the health directors and the system as a whole. So in our case, the trainings and the tools that we provided for accreditation of the GAMS proved to be very important, but moving forward, identifying those benefits more broadly would be a good approach. As with many studies, we found that moving the health indicators for chronic disease, the movement in these studies is relatively small, and we're measuring them for a relatively short time. So we were excited to see the larger change in emotional response to the curriculum, and considering the importance of individuals having knowledge about their disease on their overall emotional health and well-being. So this finding emboldens us in thinking about the rights of patients to understand their disease and feel that they have some ability to control it regardless of whether or not they choose to do so. So in moving forward, we're interested in finding more ways to measure that and consider that as an implementation science outcome.
Metasalud Diabetes proporciona evidencia de su eficacia y es viable su implementación a una mayor escala. Reconocemos la importancia de la colaboración con otras instituciones de salud.
So I think what's really important about Metasalud Diabetes and its connection to health promotion and what it does for a health system is, number one, it starts out with a positive framework of, yes, we can individually, yes, we can collectively. I think it's realistic, and at the same time, it's action-oriented, but all of those things are probably already present in health promotion, and what really changes the dynamic of something like Metasalud is the fact that it's participatory with the action, and that creates a sense of empowerment. Empowerment individually and empowerment about how we can make things better in a system. So I think if we think about Metasalud as a framework that goes beyond that, I mean, it really focuses on the quality of life that people have. And in the end, clinical outcomes are important. But if we haven't done anything to change the quality of life, then health promotion, I think, has not been able to create the outcomes in the end that we're all looking for.